Dear colleague, it's a pleasure for me. I'm thanking our host, our president, Goran Stankovic, for the invitation. And I'm going to show you all the works that's behind our EBC White paper on the antithrombotic therapy after PCI of bifurcation lesion. I have no conflict of interest to disclose. And I have to underline something that's very well known to you, meaning the swinging pendulum of length of depth duration that this is the very newly released network meta-analysis where extended depth duration, and you can see here beyond 12 months is associated with a significant reduction of myocardial infarction, but on the same time it significantly increased the risk of major bleedings. And this is particularly true when we speak about bifurcation lesions. In the definition to study, they try to have a standardization of the complexity of bifurcation apart from the Medina true. You can see here that among the major criteria and the minor criteria, you can find again a conflict between the lesions in the large vessels like left main and at the same time lesions in the small vessels, meaning that not always the extent of thrombotic risk goes in the same direction to the extent of the ischemic risk, because a large ischemic area can be less thrombogenic than a small ischemic area, like in small obtuse marginal and large left main. Which patient will be eligible for extended depth duration? And then there is no consensus for neither the appropriate PCI strategy nor the optimal regimen and duration of antithrombotic treatment that should be aiming to decrease the risk of ischemic and bleeding complication in PCI of current bifurcation. Most of the currently available evidence about antithrombotic therapy in bifurcation PCI is not derived from major dedicated studies, and that's why we have not focused the guideline approach. That's why the ABC promoted a state-of-the-art paper on antithrombotic therapy after bifurcation PCI. And key opinion leaders from Europe, America, and Asia were identified on the basis of expertise in either basic, translational, and clinical science, focusing in the field of antiplatelet therapy and interventional cardiology. All invited experts agreed to partake in the development. This was a tough work, and I thank all of them, and endorsed the advice that were provided. There was anyway no financial support and no industry involvement in the preparation of this review, and the agreement from the various scenarios we reached by discussion of the available evidence. And I'm very honored to share with all these distinguished colleagues and friends in order to have the production that was very fast. I thank your intervention for the sensibility of having a big support in their editorial staff. The paper was swiftly promoted. And for the paper itself, for the core part of the paper, we should start from the table that you will find on the paper, where are summarized the 8 studies that were focused on the depth duration. And starting from the Justino meta-analysis, that were from where there were the famous now Justino criteria, we can see that long-term double antiplatelet therapy reduce the risk of miss and this reduction is directly proportional to the complexity of the patient. If on one side is directly proportional to the complexity of the patient, on the other side it increases the risk of bleeding, and that's most evident among patients at higher bleeding risk, either identified with depth score or with precise depth score, with a lower depth score. So in other papers like our registry, there was also a message for strict following the guidelines, meaning if we follow guidelines, we are more safely giving antiplatelet therapy, and also a word for a planned procedural strategy, because we can see a bailout stenting beyond planning was associated with increased risk of thrombosis. And then we go towards a tailored approach in which clinical presentation, stenting strategy, intravascular imaging, and bleeding risk were major determinants of what we build up. And we try to build up a useful message for all researchers in modifying the usual algorithm PCI. PCI now, by guidelines, is followed by DAC duration according to clinical presentation, 6 months in stable coronary artery disease, 12 months in acute coronary syndromes. This can be modulated in patients according to bleeding risk. The DAP duration can be halved to 3 months after stable coronary artery disease, to 6 months after acute coronary syndromes in patients at high bleeding risk. But when we go in the setting of PCI of coronary bifurcation, we see that the complexity of procedures takes part in this strategy decision algorithm decision making. So in single stenting, double stenting, of bailout stenting, we have different DAP durations suggested by our panel of experts, and we can see that bailout is undoubtedly a situation in which 12 months is mostly always recommended, while for double stenting, a shorter duration in high bleeding risk can be recommended. If patients are the procedures are closely monitored and optimized by intravascular imaging, either IVUS or optical coherence tomography, then we can afford also a further reduction of DAP duration with good safety margins. So we are very happy to declare that this white paper will be released next January 2021. It has been already diffused in the preliminary part, also on the media, social medias, and we will all be delighted if you will read it and share your comments on Twitter, Facebook, or also by mail. Thank you very much for your attention.